what's separating you from lunch, so I'll try to keep this terse. These are my disclosures. I think the most relevant is that I don't have any relationship to Kimberly Clark, who has the only cooled RF device out there at the moment. But I'm sure there's other folks that are trying to emulate this. I just wanted to put this up here because the name for radiofrequency ablation changes depending on who you speak to. Some people refer to it as nerve burning. That's usually how I explain it to patients. Nerve destruction. Some people even say rhizotomy, but it's truly not a rhizotomy because it's going towards specific branches off the dorsal rami rather than the nerve root itself. And cooled RF is actually a thermal lesion. It actually heats tissue. So while it's called cooled or sometimes cold RF, it's not cryotherapy. It's actually a heated lesion. So the codes for conventional RF and cooled RF are actually the same when you ask for reimbursement. So here's just a brief case scenario. So a 64-year-old female teacher with chronic axial low back pain, and she has occasional radicular pain, but the great majority of her pain is in her back. On her MRI, she has a facet distension sign, a lot of synovitis in her L4-5 facets bilaterally. She has a very small degree of prosthesis on her dynamic X-ray films. She's had lots of treatment over the years, including different medications, physical therapy, epidurals, facet injections, medications again. She even had conventional or traditional RF, which gave her about 6 months of improvement. She's now told that she needs fusion surgery. So is this patient an appropriate candidate for cooled RF? So the biggest thing is that cooled RF is truly for joint-mediated pain. So it's important to make sure that you distinguish between discogenic pain and other sources of axial back pain. If you look at the statistics, at least by diagnostic injections, disc pain ends up being much more prevalent than facet pain, and we actually likely overdiagnose facet pain if we really look at likelihood ratios. So it's usually in someone that's a little bit older. It's usually in someone that has paraspinal back pain. And usually it doesn't refer very far. It refers into their waistline or their buttock, but usually not past their knee. We want to make sure they don't have true discogenic pain, which can present very similarly. Sometimes coughing, laughing, sneezing would indicate discogenic pain, although it's very nonspecific. You want to make sure that their dural tension is truly negative. There's no centralization phenomena using McKenzie-type maneuvers. And the imaging is really only useful if you're trying to rule out other sources of pain. Imaging in itself is not going to tell you that it's facet-mediated pain. Physical exam, we've maybe been taught that extension-based pain indicates facet pain, and then flexion-based pain indicates disc pain, but that's actually not been borne out by studies. Facet pain can occur with flexion, can occur with extension, so while we use it as an initial guide, just remember to broaden your differential if things aren't improving. And then you can use injections to try to help with your diagnosis. So other things that I use sometimes, although they're very nonspecific, if someone improves with manipulation, theoretically they have a component of facet joint-mediated pain. If they improve with sitting and walking and are worse with more of the extension-type maneuvers, then I consider facet pain more likely. And if on your manual exam there's more of a single-level segmental rotation, then you may want to consider facet pain a little bit more. So how do you diagnose facet pain through injections? Well, usually it's through medial branch blocks. The problem is if you do one series of medial branch blocks, there's quite a significant false positive. So people that truly don't have facet-mediated pain may actually respond to your first injection 35–40% of the time. So Usually we try to do it in the second setting to reduce that false positive rate to around 10%. But even with two the medial branch settings of injections, there's a degree of false positive. So the better you can diagnose facet pain, the more certainty that you have a diagnosis of facet pain, the more likely your RF outcome will be improved. So this is just a little bit of anatomy. So this is a little bit of an oblique view, and you can see the spinal nerve here, ventral rami right here, and then the dorsal rami here. The dorsal rami splits into a medial branch and a lateral branch, and once you get lower in the spine, you actually have three branches, an intermediate branch and a lateral branch. This medial branch will, of course, from the base of your superior articular process of your facet joint, and then dive medially, and actually innervates not only the facet joint, but also your multifidi. These lateral branches more innervate your paraspinals, your more superficial paraspinals, and also give you some sensation to the skin. So the medial branch here does not give sensation to the skin, but it does innervate the multifidi. So what's the evidence for conventional radiofrequency? So I know facet steroid injections have really gone through the ringer because of a lack of evidence, and actually there's quite a few carriers that don't cover facet injections or really limit the amount that they'll cover with facet steroid intra-articular injections. On the other hand, radiofrequency ablation conventionally has a couple studies that have reasonable evidence. So a couple level 1 randomized controlled trials, although in a small amount of patients. So this was the first one, Van Cleef in the Netherlands, using a kind of a perpendicular approach, and we'll kind of go over this. Found that about 50% or so of people had improvement at 6 months, whereas the controls were much less. They only used one block, and as we talked about, there's a reasonable degree of false positive when you only use one block to diagnose. And again, their placement of their needles was perpendicular instead of parallel. So this was the other level 1 study, with a little bit more rigorous with its methodology and its technique. And this also illustrates how many people you really need to get to the point of figuring out that someone may benefit from radiofrequency ablation. So they screened a bunch of people. They ruled out other things through physical exam and images. They did one block with lidocaine, and you can see the numbers went down to 22 from a start of 460 patients, and then did a second block and went down to 15. So from those 15 patients, they were randomized into getting either a conventional radiofrequency or a sham procedure. And this was more of a parallel approach, where you get more surface area of the nerve rather than a perpendicular approach, which was the case in the other study. And in this study, a much greater percentage of patients had relief at even 12 months rather than 6 months. Just wanted to show you this picture because this is kind of a perpendicular approach to the medial branch. So you can see the needle is lying down perpendicular onto the nerve. If you were to go more in this direction, more parallel, you get more surface area of the nerve, so you get a bigger nerve destruction if you were parallel rather than perpendicular. So how radiofrequency works is the tip of the needle is exposed. Radiofrequency is delivered through there. Radiofrequency creates ionic flow, which creates a lot of friction, which creates heat. So in the end, it's just radiofrequency converting to heat. And then the heat has to get to a certain temperature to destroy nerve. So it has to get to about 45 degrees centigrade to destroy nerve. And there's a little sensor on the tip of the needle that will shut down the radiofrequency if it gets too hot. As you heat more and more, you'll get more and more destruction of surrounding tissue. So the concept of the cooled RF is that it basically removes the heat from the surrounding tissue, and you get a more focal lesion, and you can actually get a more consistent temperature at the proximity to the nerve tip. So that's basically how radiofrequency works. There's a lot of other technical physics to it, but that's how radiofrequency works. And if you look back at these studies, you'll see that the technique matters. So if you have a more perpendicular approach, you get less of an outcome. If you have more of a parallel approach, you get a better outcome. If you have a bigger sized needle tip, which creates a bigger lesion, you'll actually get a better outcome. And if you lesion at multiple spots, you're more likely to actually denervate and have a better outcome. So technique matters quite a bit with conventional RF. So again, what you end up needing to do is get this portion of the nerve. If your needle's bigger, if you lesion multiple locations, you're more likely to get denervation of the facet joint. So here's how it looks like when we do it under fluoroscopy. These are Nick Bogduk's ISIS slides. So the yellow is the nerve on an AP view. This mottled red is actually the mammalo-accessory ligament. We don't think about that ligament very often, but that ligament, which sometimes can be ossified, actually surrounds or envelopes the nerve. So you actually have to make sure you're more proximal than where that mammalo-accessory ligament is. But that's basically an ideal location of the needle tip on an AP, and then on an oblique, you're basically at the eyebrow of the Scotty dog is what you're trying to get at. L5, compared to the other levels, is a little bit different. You're actually not getting a medial branch here, you're actually getting a dorsal ramus before it splits into branches. And the target point is just lateral to the S1 superior articular process. So right on the base of the sacrum at the ala of the sacrum, and your target point's just a little bit lateral. And so a little bit different technique than the other branches. So should we truly modify the traditional technique for RF? Well, we know that not everyone improves. So if everyone was meticulous and did Dreyfus's protocol, there'd still be 13–15% that didn't improve. If you weren't very meticulous and you did one block and you kind of thought they had facet pain, but you didn't want to do a bunch of procedures before the radiofrequency, only about 50% improve. So that leaves a lot of people that don't improve. So some of this may be anatomic, and some of this may be your lack of certainty with your diagnosis. The anatomic issues are that the facet joint, the superior articular process of the facet joint might be very big, and you can't get to the front of the SAP. It might be that they're obese and it's hard to get to that location. It might be that they have quite a bit of scar, and that prevents your needle penetration. Sometimes anatomy is totally distorted because of scoliosis or transitional segments, and that really impedes a parallel approach where you get more of the nerve. So the cooled RF, as I was mentioning, the cooled portion is actually attached to the probe. So you have the probe, and you have a couple other wirings that have water in it, and the water gets cooled down, and the surrounding area actually gets cooled down. So you have less impedance, and the power of your heat can actually penetrate a little bit more. You actually have a shift of this curve. I'm not going to get into this, but essentially what it creates is a bigger size lesion. So this is the conventional RF lesion, and this is the cooled RF probe. So your lesion here is going to be a little bit more oval, and your lesion here is going to be a little bit more elliptical. You actually have more of a forward penetration the heat energy that eventually destroys nerve. So you can see it's quite a bit bigger than the conventional lesion. So other things to consider is that the cooled RF not only creates this bigger diameter, but it actually goes forward more. So that's important when you're considering the risks of this procedure. You end up doing a higher duration of lesioning, so 2.5 minutes versus 90 seconds. But probably the most interesting thing is that the probe tip is actually a little bit less of a heat and centigrade than the conventional RF. So you get to 60 degrees probe tip temperature with the cooled RF and 90 degrees with the conventional RF. So once you've put this huge needle in and you're actually burning, it's actually a little bit less painful during the actual lesioning than conventional RF. At least that's been my experience. And with the cooled RF, because you have this bigger lesion and you don't have to necessarily guarantee your surface area of lesioning, you can be more perpendicular, which is much easier technically than having a parallel needle approach to the nerve. So here's from Steve Cohen's study, and this is a lesion of the cooled RF in chicken meat actually, and then conventional RF. So you can see that the size of the lesion is dramatically different. This is from the Bayless, who got bought out by Kimberly Clark, from their brochure on the cooled lesion. So again, you can be perpendicular to your target. With the cooled RF and with the conventional RF, you have to be more parallel to your target, which is technically harder. It does take a significant upfront purchase. It's $15,000 to $30,000 to get this unit, and you have this conventional RF unit, and then you have this cooling device, and then disposable probes. So another thing to consider different than conventional RF is that you're actually purchasing probes each time and not autoclaving, which can be good and bad. So the unique risks to cooled RF compared to conventional RF, we all know infection, bleeding, allergic reaction is potential risks, but for this, probably the biggest issue is being too anterior and actually burning the ventral rami. Of course, that would be bad. Motor innervation, sensory innervation to your leg. So they built in a few risk mitigating strategies, and I'll talk about that in the next slide. The other thing is, because you get this bigger lesion, are you more likely to have a post-procedure neuritis? So most people put in a little bit of steroid at the end of their procedure to try to reduce this post-procedure neuritis. The other thing I heard in the past was, do you have actually more pain? So the needle is 17 gauge versus, usually I think people use about a 20 gauge needle for their conventional RF. And it's more of a trocar probe. So to initially penetrate is more painful. But at least in my experience, when you actually do the burn, it's a little bit less painful. The other thing to consider is that these are disposable probes, so it increases the cost significantly. So each one of these packets, I'm sure you can get different deals on this, but you are in the hundreds of dollars. So and that's not necessarily reimbursable, and you have to kind of contract for that with different insurance companies. So the device itself actually has one fairly nice thing to try to avoid hitting the ventral rami. So when you pull out the probe and pull out the introducer and then put in the probe and then attach it to the needle, it's actually a couple millimeters shorter. So you're more posterior than your initial position with the introducer in. But you want to make sure that you're checking your lateral views, because anything within the foramen is obviously very dangerous. So the evidence for cooled RF is actually none. It's all extrapolated from conventional RF. So that Dreyfus and Van Cleef study, those were all conventional RF studies, not cooled RF studies. There's been lots of case reports, but really it's all been extrapolated from the conventional RF data, which does have some level 1 evidence. So what did I do with that other lady? Actually, that other lady, if you looked at her MRI, she still had some multifidi left, and she was, maybe not dramatically unstable, but she was unstable. So we ended up not doing the cooled RF because I didn't want to denervate her multifidi, which theoretically was protecting some of her instability. And so she went on to have surgery. So I'll change direction here to SI. This is a 42-year-old female veterinarian from Nebraska. She had a traumatic injury, actually a horse fell on her, and she had 2 years of extreme buttock pain. She had a bunch of SI intra-articular injections, which actually provoked her pain and didn't make her any better, and extensive therapy and chiropractic care. So just keep her in mind. So the SI joint, I often like to say, is an ear-shaped joint. This posterior joint line comes together with the anterior joint line. It's kind of like looking at the periphery of someone's ear. Usually when you enter the SI joint with an injection, you're entering back here to try to get intra-articular. There's lots of ligaments and things through there. Most of the time we think of SI pain as being from an intra-articular source, but actually there's probably a lot of extra-articular sources of SI pain. There's lots and lots of ligaments that potentially can cause pain around the SI joints. Most of the studies that we've had done in the past have used intra-articular injections as the gold standard for a diagnosis of SI pain, but you miss all these extra-articular sources. So again, you want to be assured that your diagnosis is correct. Looking at multiple studies from the same author group, basically what you need is about 3 provocative SI joint tests to really be more certain that it's SI pain. Motion testing, like Gillet's test or Stork test, is not very good. Rather, these SI joint provocative maneuvers are a little bit better, but you need quite a few of them to be positive, to be a little bit more certain that you have SI pain. You can try to diagnose this through injection, but it's not as clean as with facet injections or medial branch injections. The intra-articular injection has probably a higher false positive rate than even the faceted intra-articular injections. One of the reasons being that about 1/3 of the time, maybe even greater, the SI joint has little holes in its capsule, so all the stuff that you put in kind of goes through that hole and goes somewhere else. So you may not be blocking what you think you're blocking. So some other folks have come up with this concept of lateral branch blocks. So it's the same thing like medial branch blocks. There's sacral lateral branches that can be blocked, but the problem is that innervation scheme is quite complicated. And we'll go through a little bit of this. Most people think the SI joint has its main innervation from the dorsal structures, from L4 through S4, but primarily L5, S1, S2, and S3. There is ventral supply as well, so when you're doing any kind of SI denervation procedure or even these lateral branch blocks, you're not addressing that ventral supply. If you guys like cartoons, here's a cartoon of the SI innervation. So just to kind of orient you, here's sacrum, triangle, L5, S1 facet joint. This is the sacral foramina here, and then these little twigs here are the lateral branches coming out of the sacral foramina. The sacral branches have quite a bit more of a network. They web and join together and get convoluted. So unlike the medial branches in the lumbar spine, these branches do have some sensory supply to the buttock. They have some motor supply to sacral multifidi, and just much more convoluted. Even where they exit the foramen is quite variable. So sometimes they exit at this 7 o'clock position, sometimes they exit at this 10 o'clock position. So it's confusing, and then they can be in different depths as well. So this was back when I was a fellow. We went to New England, and there's this great anatomist, Frank Willard, who had these dissections to the point of dissecting out these lateral branches. So what we did is we got a fluoroscopy machine, put little iron filings around the twigs, as well as the foramina, and kind of showed on a fluoroscopy machine or fluoroscopy picture where these nerves lived. And they lived all over the place. And S2 was even worse than S1. S3 was even worse than S2. But generally speaking, they came out of the lateral side of the foramina. On the left side, they came out at 10 o'clock and 6, 7 o'clock a little bit more frequently, more at 9 o'clock in the S2 and 9 o'clock at the S3. So there was one validation type study for lateral branch blocks. So this was Dreyfus's study. So he blocked these lateral branches based on that anatomic dissection at multiple locations around the periphery of the foramen, as well as multiple depths. And he was then tried to induce pain through the SI posterior ligaments, and he was able to block that pain 70% of the time. So this lateral branch block technique is not for intra-articular pain, but rather extra-articular pain. And this veterinarian that I showed you earlier, she actually had extra-articular SI pain. When we did lateral branch blocks, similar to how Dreyfus did it, she had improvement of her pain, and then we did it a second time to try to reduce our false positive rate. And so she would have been, she is an ideal candidate for cool RF to the SI joint. So this is kind of more of the same. So what you end up having to do with cool RF for SI pain, where this is one technique of several, is to block L5 at its traditional location, block S1 about 120 degrees around the foramen, as well as S2 and S3 at about 120 degrees around the foramen. And this takes quite a long time because you end up doing 3 lesions at each level in the sacrum. So 2.5 minutes times 3 times all the time you need to get to that precise location. So it takes quite a bit longer than a lumbar RF. The probe is a little bit different than the lumbar RF probe, and it's a little bit of a smaller probe, and the temperature at the tip is a little bit less than at the lumbar cool RF probe. You have to create technically 9 lesions. Some people do a variation of this. Some people also go up to L4 because that has some supply to the SI joint. Some people do just 2 lesions at the sacral foramina to try to reduce time. But if you're going to do it like it's published, it's at 3 sites at the different sacral foramina. So there's been multiple protocols. We actually commissioned this study for the PM&R journal. They did a meta-analysis of all the studies up to this point, which is about 2009 is when they submitted the manuscript. So the most relevant study was actually not included. So it gave, with this meta-analysis, with conventional RF, 50% improvement in 50% of people for about 3 to 6 months. So not a lot, but some effect. Right around when this was published, as well as after, there's been a couple RCTs. This small RCT had 28 patients that had the ability to cross over if they were in the sham group. When they were initially randomized, 79% of the cooled RF got better. And again, you have to figure out what they defined as better. Usually it's 50% improvement in their visual analog scale. And then placebo, about 14% got better. And when the placebo folks were offered the actual procedure if they wanted, and 64% of those folks improved, but they didn't get actually the cool RF, they actually got conventional RF. So a little confusing. Cohen then reanalyzed his data and looked at it retrospectively, and at least with odds ratios, thought that the cooled RF was a positive predictor of a positive outcome compared to conventional RF. And then this was the study that wasn't included in the meta-analysis. This was cooled RF versus placebo, and they also had the chance to cross over, but their primary outcome time point was 3 months rather than 6 months, 9 months, although they did measure at 6 months, 9 months. At the 3-month mark, and this is where you can make the biggest inference, is cooled RF did better than placebo. It likely lasts longer, but because the placebo group had the potential to cross over after 3 months, we don't really know if it's much different than the sham. So again, so cooled RF has more evidence for it than lumbar cooled RF. And I'll end pretty quickly here. There's a couple other places where this cooled RF technology has been used. It's been used for cardiac procedures, electrophysiology. It's been used for tumor ablation. It's been used for thoracic facet-mediated pain, and it's somewhat attractive for thoracic facet-mediated pain because the thoracic medial branches are anatomically in a very variable location. They actually live between the transverse processes and in a major portion of the thoracic spine. So you're going into space rather than onto bone. So a bigger lesion theoretically would more likely get the thoracic medial branches. It's also been used in a bipolar fashion with disc biaculoplasty. So you got two needles, two 17-gauge needles that kind of come in like a discography onto both sides of the disc, and then because the lesion is the diameter is big enough, you have this thermocouple, and you basically heat the disc. So kind of like IDET, but with a different technology. Again, I don't advocate doing any intradiscal needle procedures, in my opinion, because of the Carriagee work, and actually stopped doing discography because of the Carriagee work and potential disc degeneration that happens with putting a needle into a disc. Again, with the sacral cooled RF or SI cooled RF, one other risk that I would point out is because those branches also have some cutaneous supply, you have this theory